Good evening, and a big welcome to this TOGA Highlight Symposium. I have the chair privilege tonight, and also the great privilege of being able to introduce our expert speakers to you all and chair a question session at the end of the talks tonight. We are going to talk about the highlights of early stage lung cancer presented at these three international conferences. So World Conference for Lung that occurred in San Diego in early September, the ESMO Congress occurring in Barcelona a bit later on in September, and then back to America to hear from updates from the ASTRO Congress occurring in Washington. There's going to be a focus, as I mentioned, on early lung cancer, the data and presentations from these international meetings and how it will influence our practice here in Australia. It's particularly important given lung cancer screening is coming in soon. I've had a sneak peek at the talks and we really are in for a great treat tonight. We have three speakers and also Professor Ko joining as part of our panel later on. I'm joining everyone here from Adelaide. We have Bryan joining from the Sunshine Coast, Matthew Peters and Shalini and Christopher joining from Sydney. TOGA and the speakers tonight would like to make an acknowledgement to country. The Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land on which we live and work. We pay our respect to their elders past, present and emerging. We also extend that respect to all Aboriginal people. We'd also like to say a big thank you to our sponsors, Boehringer Ingelheim, AstraZeneca and Pfizer. The TOGA vision and mission are listed here. Really quite lovely to read. The vision is to eliminate thoracic cancer as a source of death, disability and suffering. And the mission, which I think is the reason we're speaking today and highlighting the recent data, is to prevent, treat and cure thoracic cancers through research, clinical trials, education and advocacy. And this is about TOGA membership. The membership is open to anyone interested with a QR code there. Our program overview is listed here with the introduction now, and I will move on to introduce our first speaker, Professor Matthew Peters. Matthew is Professor of Respiratory Medicine at Macquarie University and works at Concord Hospital. He's a previous president of TSANZ and a passionate advocate for improvement in care and outcome for those with and at risk of lung cancer. And another little fact about Matthew is that we learnt that if you don't see him working in the hospitals, we will see him as coach for his under 13 rugby team, which he very much enjoys. So thank you very much, Matthew.
Thank you, Rachel. Yes, the mighty under 13Bs from St Joseph's College in Sydney. Yeah, that's a joy. So yeah, thanks for inviting me to talk. And I'm really going to talk about screening and early detection advances. But just before that, a little bit about what I did before. It's a fast-moving world. And bits of information I'll share with you are just a fraction of new knowledge, but things that I thought might be interesting and relevant based on my the membership of the MDTs that I'm a part of. So the first thing is that I started in San Diego at the Global Lung Cancer Coalition, and that's a group of charities and advocacy organisations from around the world. And one thing about World Lung is that ISLAC has been very good at embracing patients, survivors, and clearly as treatments have advanced, there's more of them around. And it's clear from my opportunity to talk to many of them who I've now known for many years, is this issue of shared decision-taking during extended treatment. Sometimes it's pretty obvious what we should do, as our initial treatment plan. But particularly with long-term, very long periods of treatment with, grade 1, grade 2 rumbling side effects. And at GLCC, we had a sequence of presentations from pharma, including the three sponsors for tonight. It's obvious to me that we need a lot more data for, and here's, we look at this great, you can get quite a number of credit cards between the survival curves, and it's brilliant and advanced. And we know that that if you discontinue treatment early on, it doesn't have a dramatically adverse effect on the advantage you see with lorlatinib versus crizotinib. But what we don't know is what happened to the 11% who discontinued, and we don't know about the later discontinuations, and that's relevant to the shared decisions that we have to make for someone who's having 12 or 18 months down the track really troubling grade 1, grade 2 side effects, whether it's not being able to find mapping their walks out around the nearest public toilet or cognitive impairment. So I think we should all be pushing, this is from the advocate point of view, we should all be pushing pharma to tell us those things, tell us what happens at 18 months if we stop treatment. Is that enough, or do we need to push people to continue treatment in the face of really relevant side effects? So that's the GLCC side of things. I just thought it was quickly to mention because you all have connections. I'm pushing the wrong thing. Okay, so on lung cancer screening generally, and GLCC1 wrote one of the books on how to lobby for lung cancer screening. So it's very clear that global implementation is well behind the evidence. There's poor reach at the moment to the US. Everywhere else, wherever it's trial or implementation, it's really centre-based screening, and even that's tough. And the centres where they've implemented it base their service around lung cancer specialist nurses or physician assistants, and I had a chance to talk to some of the ones in the key clinic in the UK, but no one else is doing lung cancer screening as is currently proposed in Australia. That's not to poo-poo the plan. We may be able to pull it off, but we to say is the plan at the moment is extremely different, and we'll have to accommodate very much the changed structure around GP-initiated radiology report to GP, and then logical action following. So that's really screening. Okay, so I hope you like this. Bryan talked about whimsical things. This is what happens when you ask an AI program to generate an image that says it's raining nodules. So this is done with Copilot. Anyway, new skill. Yeah, so it is raining nodules, and I was going to talk about a little bit about nodules from in terms of nodule detection, and this will be incorporated into our screening program. The PanCan schema for low-risk nodules has advantages over lung-RADS because it allows for a 2-year follow-up screen for those who are low risk. That's lung-RADS 1.1, category 1 and 2. And Annette McWilliams presented her data or her analysis from the International Lung Cancer Screening Trial. And not only does PanCan do better in terms of allocating low risk patients to a 2-year rather than 1 year, it also enriches the group of patients who are sent along to referral, so that fewer patients are referred. Excuse me, and the proportion of referred patients who end up with a diagnosed malignancy is about 2.5 times as good. So when we come up with a published schema, it'll be closer at least to PanCan, which will be one of the retraining challenges for radiology, but that will be worked through, I'm sure. At the moment, I hope this wise heads prevail, but at the moment, from talking to Dorothy Keefe a couple of weeks ago, there's actually no barrier to someone going to the screening program if they've had a CT last week, last month, or 3 months ago, but hopefully they will be revised because it's just irrational to do that. And the other message is when you see a new not solid nodule between screening, it's more likely to resolve than a non-solid nodule found in other contexts. Okay, so I'll click on the wrong thing to advance it. Okay, so just go through a few of the talks, and clearly you can download the slides, and rather than pretend I was just doing it myself, I've actually done the slides. This was about the challenges of and outcomes from incidental lung nodule program. As respiratory physicians, we're doing a lot of incidental lung nodule work. This is the Mount Sinai experience, where they interrogated their reporting database using a natural language processing, and found patients and identified them, enrolled them, and either they were they were tracked only if the patient had a clear pathway for their evaluation of the nodule, or engaged in a program if it wasn't established from the EMR that someone had done something about the nodule and followed it in a positive way. They found a huge number of nodules. They started with 4,500, got some excluded for a range of reasons, and then ended up with 3,000, of which 2,000 did have a pathway, but 250 of those 2,000 weren't following it, and then others had no pathway at all. So they were able to engage 1,000 out of these 3,000 into an appropriate nodule pathway. So a lot of patients, or patients with nodules, and not even in an elite centre, finding their way to appropriate nodule evaluation. That's a challenge. So what did they? Was it worthwhile? That's the question. So in the ones who'd been lost to follow up, they're essentially about 1,000, and their yield of proven cancers was just over 1%. The blue data are extended to just before the conference, and 70% of those were stage 1 or 2. The track patients had a bit more, but that's possibly because the nodules of greater concern were more likely to be on an appropriate track. But it's actually a worthwhile effort, because this matches the yield that we might get very hopefully from a first round of screening for patients with high-risk lung cancer. So it's hard work, and a lot of people have followed up, and those of us who are involved in nodule programs know it's hard. Okay, so the next two talks I just want to share with you about subsolid nodules in different ways, because this is what we're seeing. This is what we're seeing now in the incidental nodule, really. But this was about this one's from Yale, and what happened to semi-solid nodules in the Yale group. So they enrolled. They again. So 17,000 chest CTs looked for semi-solid or subsolid or ground glass nodule, finding just under 1,000. And then after excluding people with known metastatic cancer or where they didn't have enough documentation, they found 500 patients who fitted the category of a semi-solid nodule. 75% female, median age 70, 80% ever smokers. And so this is the interesting thing about the trajectory. Of 207 pure non-solid nodules, 80% remain non-solid over 5 years, 20% developed a solid component, and 1% resolved. Of 115 part solid lesions, 2/3 of them enlarged with an average growth rate of a solid component of 2 millimetres per year. A quarter, roughly, the solid component remains stable, and 14% actually the solid component reduced or the lesion itself resolved. And this is, I think, perhaps the most intriguing bit of data. Granted that these patients had a mean age of 70, and we worry a lot about compromising their outcome by not treating their cancer. But in fact, for the whole group, they had really high subsolid nodule-related survival. More likely to die from another cancer, including another lung cancer, separate from the nodule, or from other causes. So it's not to say we shouldn't worry about these nodules, but we need to be mindful of competitive, competing causes of morbidity and mortality, and be realistic. So I'm not arguing that we leave the nodules alone, far from it, but we oughtn't be panicking. These are the data, and we can discuss the data during the panel. The next one, again, this is an issue that's come up in the MDTs I'm a part of. That is, what do you do with ground glass nodules that appear to approximate the pleural surface? This is sort of I just happened to have a patient last week with exactly this problem, a pure non-solid, a non-solid nodule without contact of the solid element to the pleura. This is in middle lobe. Then with a follow-up, so I didn't see her then, and then I saw her last month, and now there's very clearly a patch areas of solid. The solid elements of the nodule are now in contact with the pleura. A non-smoking woman of Fijian heritage, a family history of some sort of cancer, not clear. So this is what they found, that about 300 patients with subsolid nodules who went on to resection. Again, mean age 70, mean lesion size 20 millimetres with a solid element, averaging 9 millimetres. And they categorised them into lesions like the one that my patient had, where the a solid component was in contact with pleura, and others where there was only ground glass lesion in contact, even if it was a part solid area elsewhere, or pure ground glass lesions. So what the answer amongst the resections, none of the lesions where there was no solid contact with the pleura had visceral pleural invasion. And 16-17% of those with contact had visceral pleural invasion. Visceral pleural invasion did matter, and you ended up with a lower survival if you had visceral pleural. It does matter, but that's the surgical resection specimen. But also, there's a disparity between relapse-free survival and overall survival. So in this group, like the others, there were competing causes for mortality, which went well beyond these nodules. So I'll just skip through that one. And of course, this is the other reality of to share this hassle with you. This woman, and Chris will see it at the MDT next week. In addition to this nodule, which is subsolid and in contact with the pleura, she's got to sort out a multinodular goiter with irregular FTG uptake, 2 bilateral breast lesions of uncertain significance, right ovarian mass with some pelvic nodes, and possibly something in descending colon. So amongst all these things, I'm not sure that the nodule is the biggest issue in her health, but we'll work through it all in an appropriate way. I think the last thing, so pure ground glass lesions of contact pleura should be treated on their merits as you would any other ground glass lesion. And again, this gap between relapse-free and overall survival, even in the pleural invasion group. And the last thing I can mention is this was not at World Lung, but I know it because we're getting an ENOS at Macquarie University and the Woolcock Institute. So this is from the Dutch group who have done a lot of ENOS work in airways disease, and actually the ENOS very good sensitivity and specificity for clarification of the presence of malignancy, and it may be useful if it's further validated as a way of enriching, either deciding that somebody has an abnormality that may be cancer or not, but also enriching a screening population for those at risk, whether they've been, spent their life in Asia or they've got a family history or some of the group that we're not screening. So it's really watch this space. It's very quick, and if its accuracy proves it may be one of the biomarkers that's a lot simpler to do than sending blood away looking for circulating DNA. So I think that's all I want to share with you, and I'm happy to discuss any of these things in the panel later. I think I just have to leave this slide up, Rachel. Is that right?
No, thank you, Matthew. And that ENOS model sounds very intriguing. Now, please don't hesitate to put your questions in the question and answer feature on the right-hand part of your screen. I'm next going to introduce Professor Shalini Vinod. Shalini is a radiation oncologist, so we really do have our multidisciplinary team. She works at Liverpool Hospital and is a conjoint professor at the University of New South Wales and honorary professor at the University of Wollongong. Shalini wears some impressive hats. So she's a board member of TOGA. She's also on the editorial board of JTO. And she's a radiation oncology representative for the National Lung Cancer Screening Advisory Group. So lots of different hats. So thank you, Shalini.
Thanks. Thank you to the organisers for asking me to speak on this topic of the multimodal approach to lung cancer. So I have selected a couple of presentations from World Lung and one from ESMO, all focused on stage 3 non-small cell lung cancer. So as we all know, there are an increasing number of treatment options for stage 3 non-small cell lung cancer, all of which are supported by large randomized controlled trials. So the first three boxes you see all apply to resectable stage 3 disease with similar study populations and no clear superiority for one approach over the other. And then the final box is for those patients who have unresectable disease where the standard of care would be the Pacific regimen. So the two studies I'm going to talk about add an extra layer on some of these approaches. So firstly, the addition of neoadjuvant radiotherapy to chemo-IO in resectable disease. And then the second one is adding a neoadjuvant component of chemo-IO prior to concurrent chemoradiotherapy in unresectable disease. So these are the two trials, the SQUAT trial, which is a Japanese trial adding the radiotherapy, and the Apollo trial, which is from the Spanish lung cancer group, adding chemo-IO before concurrent chemo-RT. So in the SQUAT trial, radiotherapy to a dose of 50 gray was added to chemotherapy in immunotherapy in resectable stage 3 non-small cell lung cancer. And this was followed by surgery and 12 months of adjuvant durvalumab. 70% of these patients had stage 3A disease and 83% had single station N2. 33% had low PD-L1 of less than 1%. This study did allow mutations, and there was 20% had EGFR positivity. Now, the endpoints here, the major pathological response rate of 63% and the PCR rate of 23% have been reported previously. So, just to summarize, so 30 patients were enrolled, but 29 actually completed the neoadjuvant treatment, with 27 undergoing surgery. Adverse events resulted in the cancellation of surgery in one patient and delayed in 3 patients. All surgery was a lobectomy. However, one patient did have an R2 resection where there was gross residual left behind, and 1/3 of patients completed adjuvant durva. So when we compare this small study to the larger neoadjuvant trials that have been reported, the main differences noted is this trial had a much greater major pathological response rate of 63%, which is almost double the other reports. However, the PCR rates were quite similar. Also, more patients in this trial went through to surgery compared to the larger trials. However, this did not appear to translate into any signal in terms of better progression-free or overall survival in these patients. So I'm not sure that this approach will be taken forward, bearing in mind that it is only a small study. The Apollo trial from Spain added 3 cycles of chemo-atezo prior to chemoradiotherapy in unresectable patients, with radiotherapy going up to 66 gray. And then this was followed by 12 months of atezo. And the main endpoint in this study was progression-free survival at 12 months. So 38 people were enrolled, of whom 32 completed chemoradiotherapy. So 3 out of 6 who did not progress due to toxicity in the neoadjuvant setting. Then 29 patients commenced maintenance IO, with again 2 of 3 who did not proceed. The reason for this was toxicity. In the intention to treat population, the 12-month progression-free survival was 68.4%, and the 12-month overall survival was 86.8%. So it's quite good. The 2-year overall survival was 60%. A couple of things the authors noted was that the CT DNA clearance after induction treatment was associated with better progression-free and overall survival. And as has been seen in other studies, higher PD-L1 levels were associated with improved survival endpoints. So the secondary endpoint that they looked at was what they call the Pacific survival, which was measured from the end of chemoradiotherapy. And at 12 months, this was 68.9%, which compares to 55.7% in the Pacific study. So numerically better, but again, quite a small study. But the authors did conclude that this was an approach worth considering or exploring further. However, any trial that adds extra treatment will have extra toxicities, and this needs to be considered carefully, particularly, as Matthew was saying, from the patient's point of view. So in the SQUAD trial, 48% grade 3 or 4 adverse effects, with 19% considered serious, 10% AEs leading to treatment discontinuation. In terms of the surgery, there was 71% adverse events, but 16% grade 3 plus. There was one person who died a treatment-related death, which equated to 3%. In the Apollo trial, grade 3 plus events were related to radiotherapy in 10.5% and chemotherapy in 15.8%. And then there were 8 and 6% of patients who did not continue either the induction or the completion of chemoradiotherapy due to toxicity. However, there were no deaths. And this brings me to the next trial I'm going to discuss, which is a trial looking at trying to minimize or reduce toxicity. And in this particular case, trying to reduce the risk of radiation pneumonitis. And this is a large study from China, which has looked at a fairly simple treatment, actually, at inhaled corticosteroids given twice daily during radiotherapy for stage 3 non-small cell lung cancer. The radiotherapy was either given concurrent with chemotherapy to a minimum of 60 gray, or in some cases it was also sequential with chemotherapy, neoadjuvant chemotherapy followed by a radiotherapy. And this was a large phase 2 randomized trial of 292 patients. And what they found was that all grade radiation pneumonitis was reduced from 52.8% down to 35.3%, and grade 3 plus radiation pneumonitis, which the grading means that patients would have required either supplemental oxygen or needing a hospital admission, was reduced from 28 to 12%. The rate of grade 3 pneumonitis was actually quite high, I thought, but I don't know the radiation technique that was used. And it's important to note that there is ethnic variation in pneumonitis rates reported with the Pacific regimen, and there is a higher rate in the Asian population. So they also looked at tumor endpoints in this trial and did not find any difference in response rates or overall survival. And as would be expected, those who had the inhaled steroids did have some increase in blood sugar levels. So the treatment options in stage 3 non-small cell lung cancer are becoming increasingly complex, and I've taken this slide from what Jerry Hanna presented at World Lung. You can just about have any combination of neoadjuvant treatment, whether it's chemotherapy, immunotherapy, chemo-IO, or a bit of radiotherapy thrown in for good measure. And then you can either proceed to surgery or perhaps radiotherapy. And then you can have adjuvant treatments. And this can also include targeted agents for those with mutations. There is a little box there on postoperative radiotherapy, but we definitely try and avoid that at all costs unless there's gross residual disease left behind. But I think what this slide highlights is that really it's mandatory to discuss these patients in particular at a multidisciplinary team meeting where all the treating specialists need to be present to come up with the recommended management pathway, taking into account both the individual tumor factors, but also characteristics of the patients that may sway you one way or the other towards various treatment modalities, and also their patient preferences. And sometimes there are more than one treatment option available to the patient, and then really it's the patient should have the ability to discuss them with the treating specialist and have the pros and cons of the different approaches put to them to inform shared decision making. The other point of contention in stage 3 disease is what is resectable. So the EORTC tried to define this using a Delphi consensus. And what they came up with is, towards the left of the table with N1, N0 disease and the locally T3, T4, it's all thought to be potentially resectable up to single station N2. And then towards the right of the table in the more advanced T stages or bulky N2 or invasive, then we all agree that it's unresectable. But there is a large group with question marks left in the center as to whether these patients should or shouldn't proceed to surgery, particularly because some of the trials mentioned earlier did include some of these patients. And often it does come down to the opinion and expertise of the surgeon, and definitely does differ from MDT to MDT. So I don't think perhaps that there's one solution fits all here. You have to take into account local expertise, not only for surgery, but also for the delivery of high quality radiotherapy and systemic therapy. So just to conclude, I think there are ever increasing treatment options in locally advanced non-small cell lung cancer, but we have to be careful. More treatment does not necessarily improve outcomes. Just because a pathological response rate may improve does not necessarily equate to improved survival or endpoints that are relevant to the patient. Adding treatments will definitely increase toxicities without a doubt. And I think in the future, we are moving towards a future where biomarkers will be used to guide the intensity of treatment, whether to guide increase intensity in terms of, say, perhaps neoadjuvant and adjuvant treatment, or perhaps to de-intensify treatment if patients have responded well to neoadjuvant treatment. So really trying to tailor it depending on what's actually happening biologically. And then finally, I think what's really important, and I think Matthew's already said this, is the patient voice is absolutely central in choosing the treatment pathway and also central in developing these clinical trials. And I'll stop there. Thank you.
Oh, Shalini, thank you very much. There's some very valuable insights there. And it really does look like a map of the London Underground, doesn't it? The options that people can take. So your point about having an MDT to work out the pathway for your patient to get to their outcomes is very important, and amazing to be able to treat pneumonitis. That just sounds very exciting. I'm next going to ask our audience if you've got some pressing questions to ask them of us, because we're going to have quite an interactive discussion after Bryan's talk. But without further ado, I'd like to introduce Associate Professor Bryan Chan. Bryan is a medical oncologist at the Adam Crosby Cancer Centre, as well as at the Sunshine Coast University Private Hospital. He's an associate professor at Griffith University and the University of the Sunshine Coast, and an adjunct associate professor with the University of Queensland. I think a lot of us won't forget Bryan's very colourful debate at TOGA ASM this year. And so there's lots of anticipation that I have for his talk tonight. So thank you, Bryan.
Thank you, Rachel, and to TOGA for asking me to talk about the World Lung and ESMO updates about systemic perioperative therapy. So first of all, my disclosures, I'm not actually Randall Parker, much more demure. But anyway, so I've been given the task of summarizing both World Lung and ESMO tonight, and it's like as if I had to go to Blockbuster and Video Easy and choose what we all get to watch tonight. So the pressure is on. But don't worry, I've skipped over the boring westerns, sci-fis, and rom-coms and taken you straight to the best of resectable lung cancer updates. And of course, we'll get some snacks along the way too. So here's a preview of what's to come tonight, and I've really separated this into new releases and encore updates or re-releases of studies we've seen before. So in the adjuvant setting, I'll be mainly talking about the BR31 study and then quickly updating you on IMpower 010. In the neoadjuvant space, we'll talk about the promising data from NeoPredict Lung, and then also the updated analysis from 816 and 77T. In the perioperative space, I'll talk to you about the plenary from NeoCOAST-2 and also an oral presentation on ivonescimab, and finally some updates from AEGEAN and KEYNOTE-671. So we now know from resectable lung cancer without actionable mutations, there are three main approaches: surgery and adjuvant, neoadjuvant and surgery, or the perioperative sandwich approach. Let's get in there with adjuvant updates first of all, and this was from ESMO, the BR31 study presented by Glenwood Goss on adjuvant durvalumab in completely resected non-small cell lung cancer. So the design of this study is very familiar to many of us, but this was a mammoth study enrolling over 1,400 patients with resectable stage 1B to 3A by 7th edition, and patients had to have good performance status, and EGFR and ALK patients were allowed. Patients went on to have adjuvant chemotherapy, although this was not mandatory, prior to being randomized 2:1 to durvalumab for a year or placebo. The primary endpoint of this study was disease-free survival in the PD-L1 high population, defined as 25% or more. This is the hierarchical statistical design similar to IMpower010, where the first test was DFS in the high group of more than 25%, but excluding EGFR and ALK, but of note included stage 1B patients. If that was positive, then subsequent analyses for further DFS and OS could be done. But if negative, then all of these would be exploratory. As I mentioned, this was a mammoth study including 10 cooperative groups, including Australia, and our own site participated as well. As you'd expect from a study of this size, the arms were pretty well balanced, apart from slightly more squamous in the placebo arm. This was the primary endpoint from BR31, and in the PD-L1 high group of more than 25%, unfortunately, median DFS was not improved from 60 to 69 months, with a hazard ratio of 0.93, p-value of 0.64. Key secondary endpoints for this study showed that even for PD-L1 more than 1%, or any PD-L1, did not show any significant benefit from durvalumab. Of note also, in terms of toxicity, there were no new safety signals for this single-agent PD-L1. This is the forest plot looking at subgroups, and as you can see, unfortunately, there weren't any significant groups benefiting. And in particular, given the previous Empower and Keynote studies, the question about relevance of PD-L1, and in particular PD-L1 greater than 50%, showed that it did not matter and did not favor durvalumab in this arm. So in summary, BR31 showed that adjuvant durvalumab did not improve DFS in PD-L1 high, defined as 25%, and that there was no correlation between PD-L1 and DFS. So then now we're stuck with three very similar trials with three different outcomes. And what we all want is the truth. The discussant Pilar Garrido pointed out some very important differences between the three adjuvant studies, in that there were slightly more stage 3A patients in the IMpower010 study, as well as patients who were never smokers. And what about adjuvant chemotherapy? Well, we know that IMpower010 mandated cisplatin-based chemotherapy, whereas the other two were not mandatory for chemotherapy and allowed carboplatin. This is a subset analysis from KEYNOTE-091, showing that the forest plot shows that the receipt of adjuvant chemotherapy was significant. And in addition to that, the amount of chemotherapy and the type of chemotherapy was important, favoring cisplatin. So then this is what we're left with for the PD-L1 high with the varying cutoffs here, with IMpower010 on the right, the only one showing a positive hazard ratio of 0.42, hence the approval in Europe and Australia. In the DFS in the intention to treat population, on the other hand, only the KEYNOTE-091 study was significant with a hazard ratio of 0.76. Turning now to some quick updates in the adjuvant setting. This was presented by Dr. Enriqueta Felipe, titled Relapse Patterns and Subgroup Analysis from IMpower010. But my takeaway from this abstract was really the updated DFS and OS result. So the trial design on the left is, as you can see, very well known to many of us, and we've already seen the results from DFS in the green boxes in the hierarchical design. Now, with over 5 years of follow-up, in this update, it showed that DFS in the intention to treat population i.e. including stage 1B, was not reached, and therefore overall survival was not formally tested. However, it was reported as similar between the two arms. Moving now to talk about neoadjuvant updates. This is the NeoPredict lung study presented by Christoph Coppens on neoadjuvant nivolumab with or without the LAG-3 inhibitor called relatlimab in resectable non-small cell lung cancer. So very similar to other studies, except this was included stage 1B in the 8th edition this time, and randomized patients to just 2 cycles of nivolumab alone or nivolumab and relatlimab, the LAG-3 inhibitor. Later on, the study was also amended to increase a second dose level of a higher relatlimab at 240 milligrams. This study's primary endpoint was feasibility with surgery at within 6 weeks. Now, I've shown you on this slide here the MPR and PCR rates for monotherapy with nivolumab, which is not too bad with a PCR of 13%, and the combination of nivo-rela with a PCR of 18% and MPR of 33%. Now, I think this is still intriguing and interesting because these are chemotherapy-free options, still with encouraging 2-year OS and DFS results, and there was particular significant TNM downstaging, especially in the lymph nodes, with the combination of nivolumab and relatlimab. Now, next we'll move on to the updates from 816 and 77T. So this is Dr. Ford who presented the patient-level data analysis from 77T and 816 comparing perioperative versus neoadjuvant nivolumab. So we know that from 816 and 77T, which use the perioperative approach, these both improve event-free survival. But the big question really is, which patients actually benefit from the further adjuvant nivolumab following surgery? To answer this question in lieu of an RCT, the investigators looked at 2 different subgroups from these 2 individual trials. From the 816 study, they took patients who had neoadjuvant chemo and nivolumab and then had surgery, i.e. they excluded those who did, the 20% or so who didn't make it to surgery. In the 77T population, they took patients who had completed nivo chemo, who had had surgery, and then at least 1 dose of adjuvant nivolumab. Now, with this new population, the endpoint had to be adjusted, and they made a new one of event-free survival by a central review from the time of surgery. Again, in lieu of an RCT, exploratory propensity score weighting analyses were done to adjust for clinical and disease characteristics between the groups. Now, you'll remember that in the 816 and 77T, there are approximately 400 patients. So these subgroups, which were extracted from them, represent about 140 in each arm and were reasonably well balanced in each arm. This was the landmark event-free survival, showing a significant benefit of perioperative nivolumab compared to just the neoadjuvant component with a hazard ratio of 0.61. Now, what about if you had a PCR? Well, if you had a PCR, it appears that the perioperative nivolumab did not have any significant impact on EFS. And if you did not have a PCR, there was a trend towards improved EFS or event-free survival with the additional year of nivolumab. So in summary, the 816 study is this update was the first direct comparison of neoadjuvant versus the perioperative approach, and it showed approximately a 40% reduction in death or recurrence with adjuvant nivolumab. But the question now is, which of these 3 approaches is better, adjuvant, neoadjuvant, or perioperative? And hopefully studies like this one from the Chinese group ECTOP will hopefully help to answer this. So this is a randomized phase 2 study of 200 patients asking that exact question, comparing the Empower 010 regimen with adjuvant atezolizumab, neoadjuvant nivolumab as per 816, or perioperative pembrolizumab as per Keynote 091. Changing gears now and talking about perioperative updates. So this is the NeoCOAST 2 study and the ivonescimab studies, both phase 2 studies from Well Done. And this was presented first by Dr. Tina Casconi, which is the efficacy and safety of neoadjuvant durvalumab with novel anti-cancer agents. So this is a busy slide, and essentially the eligibility criteria for inclusion is very similar to all of our other perioperative studies, and there were 4 arms in the study, but we are only going to discuss 3 tonight. The first is oleclumab, which is an anti-CD73 antibody. this combined with durvalumab and doublet chemotherapy. The second is monalizumab. It's an anti-NK cell suppressor drug with durvalumab and doublet chemotherapy. And the fourth arm is datopotamab deruxtecan, or a TROP2 antibody drug conjugate with durvalumab and single agent platinum, because of course the ADC has a chemotherapy component already. In this study, the primary endpoint was pathological complete response and safety, and it was not designed to compare between arms. In saying that, baseline characteristics were well balanced across arms, apart from a slightly more PD-L1 positive patients in the ADC arm, number 4. In keeping with real-world practice, majority of patients received carboplatin as their platinum backbone. It's nice to see here in the treatment disposition from this trial that pleasingly over 90% of patients managed to get to surgery. Now, this is not designed for direct comparison, but you can see that between arms 1, 2, and 4, with oleclumab, monalizumab, and Dato-DXd, the PCR and MPR rates are increasing to a promising 34% with Dato-DXd and 65% MPR rate with the combination. As you'd expect with toxicity, again, this was incremental from arms 1, 2, and 4, with the combination ADC having 18% grade 3 treatment-related adverse events and up to 7% discontinuation rate. Now, what were these adverse events? Well, the majority of them were neutropenia, thrombocytopenia, anemia, and asthenia. So NeoCOAST-2 was the first study to show activity of an ADC in resectable lung cancer with promising PCR and MPR and acceptable, well, sorry, not acceptable, but better surgical rates of up to 90 to 96% and manageable toxicity, including in the ADC plus chemo plus Durva arm. Next, I want to show you this, and this was presented by Dr. Zhao. You might have tuned in last night where Dr. Kwok talked about ivonescimab at the Harmony A plenary, and this is the bispecific antibody for VEGF and anti-PD-1, but this time being used in the perioperative resectable lung cancer space. So this is a Chinese study using 60 patients, predominantly squamous and predominantly stage 3, and they were randomized to ivonescimab monotherapy or ivonescimab doublet with chemotherapy at 2 different dose levels. Following surgery, ivonescimab was continued for a further year. Now, this is a caveat, is that these are very small numbers, but despite that, there were still promising PCR rates of 30% in the monotherapy and 43% in the doublet arm. This is the safety profile, and I think the authors reported no major toxicities, including bleeding or post-op delays or cancelled surgeries. However, I think they got a bit unlucky in the ivonescimab monotherapy with 36% grade 3 immune-related toxicities. So in summary, for ivonescimab, it showed, in combination with chemotherapy, it showed promising PCR rates of 43%, and particularly in the squamous subgroup, 63% pathological complete response. In the monotherapy chemo-free option, PCR rates were 30% and 60% MPR respectively. And whilst the authors reported that no TRAEs led to cancelled or delayed surgeries or wound healing, I noted that there were 11 patients who did not get to surgery from progression of disease or patient request. Now, in the last few slides here, we're going to talk about the Aegean updates and Keynote Segment 1. So this was from John Haymack, updated outcomes from the Aegean study. Very similar design, except this was durvalumab plus chemotherapy. And in this subset, the modified intention to treat analysis excluded EGFR and ALK. So here you see that event-free survival showed sustained benefit with hazard ratio of 0.69, and overall survival is immature with only 33 months of follow-up, but there was a trend towards durvalumab benefit. This is the Keynote 671, and what I really wanted to show you here was pathological regression. The design is really the same as all before, but using pembrolizumab instead. And moving beyond PCR and MPR now, we're also reporting residual viable tumor. So in the pembro arm, the residual tumor was 29% median versus 52% in the placebo arm. And why is it important? Because residual viable tumor is correlated with event-free survival, both in the pembro and in the placebo arm. And it is to a certain point. So in this, on the left-hand side, you can see for RVT between 30 to 60%, pembro still has a benefit in the adjuvant setting. But where there's a bulk of tumor remaining more than 60%, then the addition of pembrolizumab seemed to be diluted. So the question is there benefit from giving the same immunotherapy after that if you haven't had that response, or should we be looking at other things like escalation? So in summary tonight, we've been through multiple different studies in different settings tonight. And where do I see the future? Well, I think with screening that Matthew spoke of before, we are looking at a wave of resectable lung cancer coming. And it's nice that we have mature data for adjuvant, the neoadjuvant and perioperative setting. I think it's good that we have emerging chemotherapy-free options. And I think ideally we should have a platform study where we can look at escalation or de-escalation as appropriate, and even looking at novel things such as incorporating radiotherapy. I think importantly, harmonization of response criteria with RVT and meaningful cutoffs based on EFS and OS could be useful in the future, as well as novel agents such as ADCs, vaccines, and immunotherapy agents. And finally, I think it's important, just like all our speakers have mentioned tonight, about the importance of biomarkers, ctDNA, in making sure we can bring this cure forward and help more patients with lung cancer. Thank you.
So thank you, Bryan. That was a lot of data to cover. And so we'll let you have a few more minutes because it was such great data that you've presented. We also have Professor Christopher Kao joining our panel. He's a thoracic surgeon from Sydney, well known, I'm sure, to this audience tonight. So we've got quite a few things I think we can talk about. I'm going to encourage people to ask their questions as they come to mind. But I'd like to ask Matthew, you talked about these semi-solid nodules and if they touch to the pleura and all sorts. What's your threshold in your mind for acting on a nodule find, these raining nodules? Is it size, how solid they are? Is it the change over time? But what's your threshold for asking Chris to cut them out?
For pure ground glass lesions, I'm increasingly enthusiastic for watching them, no matter if they're frighteningly big. And for solid lesions in someone who's got an advantage of resection or other treatment where the solid component is visible and growing, or a new solid element, that's when you need to begin a discussion about resection, or if someone doesn't want surgery, SBRT as appropriate. But yeah, I think leave the pure ground glass lesions alone, worry about the part solid ones. And we can now confirm them pathologically, particularly as CBCT biopsies become more readily available. Hopefully they will. So that's my thing. Is you worry about the solid component and have that shared decision about whether you want it to be now, or 3 months, or 6 months. But I don't think we should be saying you've got 3 or 4 millimetre ground glass, solid component in your ground glass lesion, you need to have an operation tomorrow, because that data don't support that.
Thank you for that. So I'm next going to ask Chris, to hear from Chris. N2 disease, we've now got the 9th staging system available to us, and there's 2 components to N2 disease. What does this require of you for surgery? And does it change your surgical approach, this new staging system, and the outcomes of the studies that we've presented this evening?
Thank you, Rachel. Really appreciate your question, but I might just quickly touch on the previous questions to Matthew. I think that what he presented was very interesting for the surgeon to decide the important decision of a segmentectomy versus lobectomy. Yeah. And because first of all, segmentectomy, as we know, JCOG 0802 demonstrated superior survival and is now a feasible alternative approach to lobectomy. But one of the most difficult decisions is to know which patient to select. One of the worst things is you do a technically challenging but successful segmentectomy, and it comes back with micropapillary component with a visceral invasion. And the patient has 1B disease, and you're kind of kicking yourself wishing you had done lobectomy. So what he presented today with solid component on the pleura having a higher risk of pleural invasion does kind of help me, despite working with excellent pathologists led by Wendy Cooper. Sometimes intraoperative assessment of STAS or subtyping or visceral invasion is very difficult. So what he presented was actually quite educational to me. Now, moving on to your question about multi-station N2 disease, I think the staging system has taken many years to evolve from the 8th to the 9th edition. And I think they're trying to draw the line for multi-N2 stations as non-surgical, deeming it a higher stage of stage 3. What's interesting in my mind is the recent evidence from Checkmate 77T, I believe, the perioperative study demonstrating quite a good outcome for patients who've had multi-station N2 disease involvement, and the divergence is even higher compared to chemotherapy alone. That is to say, perhaps new evidence will suggest that patients with resectable stage 3 disease, even if it's multi-station N2, may have quite encouraging outcomes in the regimen of neoadjuvant chemo IO followed by surgery. And so my point to you is that once the new staging system comes out, the new evidence may make it not so clear cut as the people who've done the staging intended to be.
Okay. No, thank you for that. And I think just for really all the panel, really, but maybe starting with Bryan, after BR31, for your patients and the recommendations that we all make in the MDT, will you be recommending surgery for any groups, stage 2 to 3 first up, or is that going to sway how you feel about neoadjuvant chemoimmunotherapy?
I think it's obviously it's a multidisciplinary decision about who goes to neoadjuvant versus surgery first. But I think if there's somebody where you have a high PD-L1, more than 50%, and they have a stage 2 and there's equipoise, I think that's where you can certainly say, well, I feel comfortable having surgery and adjuvant chemotherapy. But I think, yeah, I mean, as we've all talked about tonight, the patient preferences, the MDT decision is critical there, but yes, I guess we were hoping to have a trial that would answer all our questions, but nonetheless, we've just left with more questions.
So you would say maybe for someone with a lower PD-L1 expression, you'd probably veer on the side of neoadjuvant chemo IO first, or
well, with our current reimbursement climate here, particularly as well, given that if you have PD-L1 low, then in the early space you can't access immunotherapy unless it's in the neoadjuvant setting. So yes, or the perioperative setting if that gets approved.
Yeah, so I guess we're really hoping that will evolve, that space. Very much hoping, especially with that. The recent comparison that Patrick Ford did between the two trials, showing that there is a benefit, particularly maybe in those who haven't had that PCR or have low expression, to give the extra immunotherapy after surgery. So yeah, just to summarise, I guess, so if a patient of yours had no PD-L1 expression, what would be your sort of recommendation in stage 3 disease?
Resectable.
Yeah.
Yeah, well then I guess that we can consider if they're reasonable for neoadjuvant. But I think with all of these studies as well, we have to remember there are people who I think we really have to be so careful with our selection, because I worry sometimes if we choose based on excitement to go down neoadjuvant pathways and patients fall apart with toxicities. And then you think, oh, geez, so should I have done, should we have called them unresectable at the beginning and given them a different pathway of treatment? So, and certainly I've had recent regrets with patients that we've selected for neoadjuvant pathways. So I mean, I think the initial excitement of all of this gets people choosing that pathway. However, at the end of the day, we have to realize we're not treating all the trial patients, we're treating real world patients with every day.
Yeah, that's very true. Chris had a comment, I think, to make. Yeah.
Right, Rachel, sort of my contribution is really that I'm sort of thinking about the easily operable stuff should still go to an operation. The barely operable, think about your neoadjuvant options. And then there's additional group which, we haven't thought of operable, and maybe we need to think about just on the other side of barely operable, that maybe neoadjuvant with a view to surgery if they do really well. But Chris might want to comment on that. That's just my thinking, which is sort of the way I do a construct.
I just want to make a comment. I really enjoyed Shalini's talk, but I think the age-old question of resectability and operability obviously depend on the patient's overall status, but the resectability is different according to each surgeon's experience, and it unfortunately cannot be simplified into a box that's similar to the staging system. I think that is a little bit dangerous to deems a patient unresectable because they fall into a particular part of the box. It should be really reviewed by a surgeon by imaging individual basis.
I think that's very, very true. And we've got a good question that's come through, and it's for you, Chris. So how do you feel about the bispecific anti-angiogenic agent preoperatively, and the promising tolerability data that was presented, because it is an anti-angiogenic that's part of that treatment?
I think, like all novel agents, we'll have to look at the treatment-specific adverse events and how that may impact on surgery. Certainly, I think with immunotherapy, with more maturing data, we now know the safety profile is quite reassuring. But as with any other novel agents, we need a little bit longer follow-up, and especially with a surgeon's perspective as to what intraoperative challenges they may encounter that's unique to the agent.
Yeah, no, it's very true. We need a little bit more time, don't we? And Shalini, I think I was quite intrigued that in the SQUAT trial that the PCR rates were fairly similar, but the MPR rates were different, suggesting that we're probably just not getting that depth of the response with the radiotherapy. Would that be your thoughts about that?
Yeah, I think previous studies have shown that when you add radiotherapy in the preoperative setting, it does result in improve response rates. I haven't particularly looked at the PCR rates, but I think radiotherapy is having an effect. The question is whether it translates into any improved survival. And look, adding radiation on top of surgery in whichever sequence before or after will definitely increase toxicities. It's like having double local treatment. And I think from my point of view, it's something you want to avoid. You want to select the best local treatment for that particular patient and then combine it with the appropriate systemic therapies. So it's sort of a bit like Back to the Future, as Bryan was saying, neoadjuvant radiotherapy has fallen and adjuvant have both fallen out of favor. I think the only situation where we'd be considering it in the current sort of climate would be for like a Pancoast tumor, where there's data to support it to improve the operability. But otherwise, I think any neoadjuvant would be largely systemic based.
Oh, that's fantastic. So, really like to thank everybody for attending tonight, and we hope that you've learned a few new things from this wonderful presentations this evening. There will be a TOGA lung cancer preceptorship if you'd like to join that towards the end of November. We've also got the ability to provide some feedback, and I'll just bring up the right slide for that. So please feel free to provide some feedback about tonight's event. So very much thanking you for joining us.